We've seen lots of reports come out recently about the differences in general practice. And in this episode, Andy and myself have basically just finished looking at the Future of General Practice report by the Health Select Committee. And we thought we'd take a few minutes, 15 minutes in fact, just to think of our own changes. These changes are completely different to what you may expect because we've particularly picked things that you wouldn't normally go for. We've tried to make this a bit broader, a bit more unique and that kind of stuff. And in this episode, we're going to find out what each other think because we've not even seen each other's ones. So let's crack on as we tech enhance our primary care and learning. Hello, AGP learners, and welcome to this rather unique episode that me and Andy have done. So just to summarize, we spent 15 minutes after reviewing the Future of General Practice report by the Health Select Committee. And if you want to check out our previous episode, feel free to do so. It's probably going to come up at the end of this one. But in those 15 minutes, we've just been beavering away thinking about what could we change in general practice / the NHS that would be helpful, useful from our perspectives, but also not something that's really been mentioned already in all the previous reports. And that's where the little complexity of this little exercise has come into play. And we'd love to know your thoughts on this. So definitely jump into the comments and stuff and let us know. And if you find us on Twitter and that kind of stuff, absolutely let us know as well. But it's been an interesting exercise, hasn't it, Andy?
Yeah, I'm really liking this new format. It's really fun to just have 15 minutes, often limitations mean you come up with something really interesting. And we've spent a lot of time over the past few weeks and months, haven't we, looking at various policy documents. We had the Fuller report, the Health Select Committee report, various statements from new health secretaries coming through, Sajid Javid's report. So it's interesting to have all of that loaded in our brains and then come up with some new suggestions within 15 minutes about how we would shake up general practice. So really excited to see what you've come up with, Gandhi, actually.
Same here. And just to emphasize, me and Andy haven't discussed these with each other beforehand. So completely no idea what the other person's written or anything like that. We're going to go through them. I know you wanted to start off by explaining yours, and I'm going to add it to the stream. So go for it, Andy. Tell us what this means.
Yeah, so the policy committee, which is me, so we fully accept and endorse Jeremy Hunt's recommendations. We think that's a really good starting point and a good building block. We've called our policy framework General Practice Unleashed because we feel that there's so much potential with general practice, but the way that we have been working over the past few years has been holding us back. So look how happy those dogs are now they've been left off the leash to run and do what they were born and trained to do, which in our case is to look after patients. And then the strap line underneath, reborn as family medicine. So I've increasingly had a bit of a problem with the term general practice because I think we use the same words to describe too many things. So, we are GPs, so we're general practitioners. The organizations that we work for are general practice surgeries or GP surgeries. The sector we work in is also general practice. There are other people that work for us, like nurses and lots of other people that work within a general practice. Just really confusing. And then it leads to misconceptions, I think. So when people say, we're going to pay GPs to find new cases of dementia, or things like that, people think, oh, that's money going in GPs' pockets. So I just think the language is just too old-fashioned. So I'm going to have general practice reborn as family medicine. I think the Americans have probably got it right. So we're going to call the sector and our organization family medicine, and we're just going to be called GPs ourselves, and that's going to just represent us as individual professionals. So that's the explanation of what I've called my my policy framework, Gandhi.
Okay, so it's interesting. I didn't even consider the name for the framework or anything like that. So mine is completely just practical in there kind of thing. And so I've termed it Dr. Gandalf's fixes to general practice done in 15 minutes. So kind of what it says on the can of the tin. But yeah, I like the way that you've approached it. Actually, in reflection, I would have loved to have gone, more policy-ish and added that kind of context in. So
it's just theatre, Gandhi, but I do stand by my point about family medicine.
Yeah, definitely.
I've been learning from the government about theatre and framing. So.
Wow, definitely. I might have to consider that as we go from draft 1 to draft 2 then. But as we have a look at it, so I'm going to kick off and go with my first change. And this is a bit weird, but I think it's going to make a massive difference to the working life of everybody in general practice or family medicine, as you're going to call it. A universal GP IT login. So every clinical system that we use will be required to use the same login passport system. An e-smart card. This has been talked about for many years. And actually, I'd just like to see it happen. People to get off their cans and just actually fix this and make this a reality. And I think in terms of stress, in terms of engagement with systems, in terms of just usability, functionality for clinicians, I'm a digital GP. I'm going to look at the digital interface first. Fixing this would be mind-blowing for many people. You've got your smart card, use that for everything rather than having multiple logins and that kind of stuff. I know I talk about having password managers and stuff as a fix for a lot of this for many people. If you don't use that currently, then you need to start doing so. I'll put links down below if people want it. But this, I think this would save so much stress in so many different ways and actually make IT provision more modernized and more effective. It's so easy to do, but it just requires people to do it.
Yeah, I love it, Gandhi. I'm sold, and it'd be good. We use lots of different computers, different different systems, and I do have to remember a lot of passwords. It'd be great just to rock up to something, put my card in, or my my RFID thing, and wave it at something, and then I'm logged in, as me on that system, because we work in different locations, often different organisations, don't we? So this would make it a lot easier. Yeah, I'm sold. I like that one, Gandhi.
Cool. All right, I'm going to switch over to yours, Andy. Go for it. What's your first point?
So I think I've been a little bit more grandiose in my plans. I think I'm in number 10 or number 11 Downing Street, really. So let me just move across because I've got some animations as well. So coming in. Ooh. So we're going to have one-stop family medicine hubs in every community up and down the country. And they're going to be for both acute and chronic family medicine, family medical care. And we're going to prioritize continuity within this. So actually, and some people may have noticed that we may already have something very much like these. So these could also be known as GP practices. So we've actually already got these. So what we're going to do is actually focus on GP practices more in this new world of general practice unleashed. And we're going to worry a little bit less. We think that there's value in primary care networks and practice working together, but the GP practices have been somewhat neglected, and actually they're really well placed in their geography and where they are. And actually, there's great people that work in them, and we're going to invest more in general practices. Further, and this is potentially a controversial bit, actually, we're really going to run with continuity as described in Hunt's Health and Social the Select Committee report. And actually, I'm going to say we're not going to separate acute and chronic care into different streams. We might do that within practices, and groups of practice might choose to do that, but that's not going to be a big policy focus. And actually, we think that when you're seeing people with their minor ailments, that you're building up continuity and relationships that can be leveraged further down the line when those people might have more pressing or more serious health needs. And actually, we're going to deal with everybody together. And we used to do it really successfully before people started fiddling too much, I think. So we're going to go back to basics. So that might be controversial. And I say some of these things, they might not be possible, Gandhi. So I'm being a bit grandiose, but I'm setting out some principles. So put it out there. What do you think? You sold?
So you're talking about basically community hubs, community care hubs, effectively, and having them as the focus point, i.e. the general practice being the community care hub and stuff. I think, it's a mishmash of the Fuller and and the Health Select Committee kind of melded together, having a love child, and actually it ends up being your grandfather, because actually that's what general practice used to be.
But you still love him because he's your grandfather. So that's really weird. But I think you've represented it quite well. So I think back to basics a little bit and just investing what's already there and working and make that better.
Okay, fair enough. Let's switch over to my second option. And so let's go back to this. Number 2 I had was universal NHS jobs passport. Okay, so why have I picked this? Well, one of the challenges we have in general practice, whenever somebody joins a practice, moves from a different part of care to a different, and there is so much bureaucracy and paperwork and crud that goes into onboarding people. Everyone has to redo all their training when it's already been done, possibly in other roles. It has to all be re-updated, even though they may have just done it. DRB or whatever it is, and all those kind of stuff that actually people are just having to repeat and rinse and repeat over and over again. Actually, this would be so much more sensible if there was just a single usable database that people could use, linked into your universal login. See how we're going here? Yeah. Integrated kind of systems and stuff, and particularly for our practice managers out there, I think this would be an absolute godsend. So they're not having to chase everything. And you would absolutely include things like your indemnity in this, your GMC registrations, all those bits and bobs that actually would just flow. And this is what the performers list was meant to be, but for some stupid reason isn't. It's still segmented. It's still, none of that tracks across. You could easily take this further and integrate it with the appraisal revalidation scheme for GPs, and then for obviously other roles, NMCs and stuff, have that integrated as well. It's doable, it's feasible. It would make bureaucracy almost disappear for a lot of the onboarding of staff and maintenance of staff as well. Universal job passport.
Yeah, you're really, really practical changes here, Gandhi. I can see a theme coming. I think you're going to be quite practical, and I think a little bit.
Oh, no, I've got some the box ones coming. Don't worry.
You're building. But yeah, I can't disagree with that, Gandhi. There's a lot of. The other thing was, would you carry your sort of stat and man training, across your different organisations and when you change jobs as well, presumably, so you don't need to redo those things, those can carry or do them for multiple organizations.
Exactly.
Really nice
we are seeing an increase of portfolio working across, particularly for GPs, but also other roles as well. Other clinical roles, nurses, pharmacists and stuff may work for multiple organizations. Why do you have to repeat the training for every single organization? It's lunacy. We lose so much time because of this. So one single passport that requires, it's doable, it's feasible. It just requires somebody to just do it and stop being so precious about the fact that it all has to be on various different individual databases and that kind of stuff. Make it happen.
I'm sold. Yeah, so certainly the portability of completed training and things like that are really, really good as well. Yeah,
cool. Good. All right, Andy, flipping over to you.
Okay, so it's another big one, and slightly mischievous in a way, in that it may not work or the figures may not stack up, but there it is. So I'd like to see a new GP contract, okay, or a new family medical contract, as we're calling it now in our new language that we're using. And we're going to have activity-based contracts for what are now GP partnerships. They might be family medicine partnerships. We're not quite sure what we're going to call them in the new world. But at the GP partnership level, I think actually an interesting idea would be to have activity-based contracts. So what this would mean is that when there's a GP appointment and it happens, there's a tariff or a fee for that GP appointment. And for every GP appointment that happens, then that tariff's paid to the provider of that appointment. Some people might even think it works a bit like this already, but it totally doesn't. And what that would mean is actually, so in places where there's high demand for appointments, actually the funding can flow to those areas. So that high demand for appointment, okay, that means more tariff, more funding goes there. That attracts the workforce in as well, because there'll be the money there to pay for more GPs, more practice nurses, more pharmacists, more whoever. And in the areas where there is lower or less demand, which people might say that's nowhere, but I think patterns of demand do vary, the money sort of moves from there. So it's almost using market forces, which often conservative governments talk about, and Tony Blair, Labour governments talk about as well, to allow for funding to flow to where it is needed. Now, what people will say is, okay, but somebody needs to control demand, or there's a bit of a perverse incentive to keep booking someone back in for their blood pressure to be checked every week or something like that. So actually, there will be people that look at that in the new primary care system, but it's not the people who are providing the appointments. I think that responsibility needs to be held somewhere else. My argument here is that I think that most GP partnerships, as they are at the moment, are too small now to carry the can for demand management, and they don't actually have the levers that they need to manage demand management. And actually, the government often writes a bit of a blank check for demand when they say, okay, see your GP within 2 weeks now or 1 week now, but they don't actually have the direct responsibility for providing that. They push that down to GP partners. So I think actually, if they're going to talk that talk, they're going to have to hold the can for the effects they have on demand. And GPs are going to do what they're good at, and they're going to see patients, and their staff are going to see patients. They're going to care for patients, and other people are going to manage the demand, because I don't think that should be done at GP partnership level anymore. I'm being playful. I've not really thought these out in full,
That's
but
interesting.
just raising questions.
So
Are you signing up for it, Gandhi?
I think that's really interesting. I think absolutely looking at the funding flows demand aspect is something that needs to happen. Obviously, the Health Select Committee said there needs to be a review of Cahill. I see this as a different thing. Cahill focuses very much on deprivation-led aspects and the challenges there. So this is definitely a bit more out of the box and definitely more interesting. I think it feeds a little bit into my number 4. So as a spoiler,
Okay, that's interesting.
I think my number 4 complements it. I think that'd be really interesting. But you make that valid point about other people tell people to go see general practice for their own specialist interests. The third party groups, the individual condition specialists, kind of charities and all that kind of stuff. And the government's the biggest culprit of this. Go see GP for everything because we don't want to deal with it and we want to devolve that responsibility somewhere else. But actually taking some responsibility of it in a sideways kind of method would be really interesting, I think. So, and when you make the payment flows with it, then it takes everybody's responsibility into account as well.
Yeah, good. Oh, thanks, Kenny. I thought I'd lost you there for a second when people start describing your ideas as out of the box and interesting. That sometimes mean they don't agree with it, but you were generally supportive. Okay, that's good. I'm glad that landed the way it did.
Cool. All right. So going for number 3 now, I'm going to switch over. My number 3 was, so I'm going a bit more, into it. Things change prescription exemptions. I've mentioned this numerous times. It's an archaic system that we have in terms of who gets prescription exemption charges and stuff. And this can be deliberately broad. I've just said change the exemptions. But, absolutely there is the option of making this free prescriptions for all, which is what they've done in other areas of the devolved nations, Wales and Scotland. You get free prescriptions. In England, we're we're the only nation where you charge people for their prescription access and stuff for individual prescription charges. But the exemptions that exist have not been updated for at least 20 odd years or so, and I think it does drive a lot of the health inequalities that we see. So the fact that if you have asthma or COPD, conditions that very much require good compliance with treatment, that you won't have those treatments for free or access them, which then can impact your compliance unless you're in some of the exemption groups like under 16, over 60, that kind of stuff. Whereas if you've got hypothyroid disease, quite rightly you should be getting your thyroxine constantly because you need that to continue living effectively and safely. But why does that mean you get everything else for free for perpetuity and stuff? That seems a weird complex, considering actually that may have an impact on other health issues and it may not do actually. So that's a real disparity, real inequality, I feel, and actually changing the way that prescription charges work. There are various ways you could do this. Absolutely, it's up for debate, but I think we need to have the debate at the very least, and they need to change those exemption reasons.
Yeah, I love the way you're suggesting things that are actually possible and implementable and practical with your suggestions, which mine are not. But no, that's you're absolutely right. The way the current system works doesn't really feel like it makes really much sense. To be honest, there are things which, as you say, allow people to get all of their prescriptions free when actually it's only sort of 1 or 2 very specific medicines that they would need for free for that condition. Thyroid dysfunction is the main or the best example of that, and people have lots of long-term conditions that require lots of prescriptions and they don't get any of it for free, so it just doesn't make sense. So
to be clear, I would not be averse to even actually going the other way and saying that actually we charge for prescriptions but reducing the charge and making all prescriptions chargeable. That's going to drive some other health inequalities and stuff. But I think there's also that element that the amount of waste that we have with medications because of over ordering, because of irresponsible prescribing in some parts. One of the things that really frustrates me as a GP is, people ask me for medications to be prescribed on behalf of other people because of the increasing use of skill mix and stuff. And actually, the one that really annoys me is hosiery. You know, that they haven't been sized and stuff. Oh, it doesn't matter if they're the wrong size and stuff. Actually, it does, because that's a prescription cost that's been dispensed and you know, done, and that's wasted. And then the other one, I'm just going to sidebar into it, is the legislation about pharmacists not being able to prescribe alternatives for medications. That would have a bonkers effect on general practice in terms of saving the amount of workload that currently goes on. But in terms of, you know, I'm sure you know this, particularly with the supply issues that we have. If I prescribe, you know, sertraline 100 milligrams, but actually the 100 milligrams is currently out of stock and they can only supply them in 50 milligram tablets, rather than just being able to do that, they have to have another prescription that wastes time for us and waste time for the patients and things. So I'm going to shoehorn that one in, even though it's not on my list, but I've just realised I really
we'll let
put
you,
that
we'll
one
let
as
you have
well.
that. Rationalising prescription exemptions and systems. Yeah, really, really good. Yeah, I'm behind that one, Gandhi. You got to sign me up.
Cool. All right. So switching over to Andy again for point number 3.
Okay, let's see. What did I put for point 3? Okay, yeah. So this is running with some of the concepts already. So we're sort of removing restrictions, as you see. We're unleashing general practice, as you get from the name of this. Another sort of radical idea to think about, I think, would be to remove most of the strings. I put most, but remove practically all the strings attached to funding allocations. So a prime example of this is the primary care network ARS workforce, where you can only spend it on certain things. For example, I just say let's not do that anymore. Let's actually just give general practice, or family medicine as we call it now, a job to do, and we can define what that job is and what we mean by that job being good in terms of quality measures or in terms of outcome measures. But then let's just give them the money and they can make decisions about who they want to employ and how they want to employ in response to demand and the incentives that are put in place in terms of outcomes. So if in their particular area they need more nurse prescribers, then that's what they'll be able to get, to achieve the outcomes, and that might mean that there's more demand for nurse prescribers and so forth. But then I would say the rest of the system needs to adapt to that and needs to, everything needs to deliver what's required. We can't just say, oh, you can only have certain types of workforce because we know other people aren't there. I mean, that's very temporary thinking, I think. If we need more of a certain type of workforce, then that's just going to have to all feed all the way back through training. If we need more GPs, people want to employ more GPs, then we just need to provide more GPs. So sort of just be less restrictive about how we use funding and trust local organizations to make the right decision about funding. There we go.
I think in terms of unleashing general practice, Andy, you may have just caused heart attacks across various NHS managers by suggesting that particular one. They're like,
I mean, workforce chaos potentially, but
yeah,
but let's have I don't know, let's put it on the table, eh? Why not?
Definitely an interesting one, and like I said, I think several people in the NHS England are probably thinking, Andy, you're not allowed anywhere near us for that one. But you're right, it would be game changing in terms of reducing bureaucracy, in terms of actually providing local based workforce for what's needed. I think that would be really useful.
Yeah, I'm saying, presumably, I'd love to look in more detail at other health systems, but in America is maybe not a shining example. But I imagine other health systems, organizations have a budget and they choose who to employ with that budget. I mean, is it really that radical? At the end of the day, I'm not sure it is. Or I challenge people who might say it's too radical. Anyway, prepared to move on. There you go.
Okay, so we're going on to number 4. Now, I mentioned that my number 4 might complement your number 2. So let's see if you agree with me on this one. So switching over, and my number 4 was NHS public campaign on the roles and services to help educate the population and the workforce about what is currently and available, and more importantly, feasible. Okay, so the fact that actually there are a variety of different roles that can help you with your various health issues. There isn't a national campaign about this. They're leaving this up to the regional areas and the local areas and the practice and stuff as usual, rather than taking responsibility to inform the public about what's going on. And more importantly, around the services, in terms of the fact that, yes, we see in the media all the time about the NHS being strained and that kind of stuff. there's very little centrally created information about responsible access to healthcare, about understanding how the healthcare systems work and stuff. It's left up to organizations like the King's Fund, like the Health Foundation, Health Watch, all those kind of things. It's not centrally run, supported, or anything like that. And actually, therefore, it doesn't go through the central media channels that we need it to go through in order to help inform the public and educate them about the use of healthcare services, particularly a socialized, nationalized healthcare system. And this would be really useful for those coming from outside of that system, particularly those coming from abroad, to understand the difference of how the NHS works compared to their home healthcare systems, which actually is one of the reasons why we have so much conflict in the way that we deliver care, particularly for those populations. Actually, if they had that onboarding experience, and I know I've talked about this numerous times, I think that would make the journey for many patients so much more effectively, because then their expectations are set in terms of what is currently available, not what they want, which is different to what they may need and be provided for.
Yeah, I really like it. I think honesty about what's actually possible, what's actually available, what's actually provided, coming from the government, because I mean, they're purchasing all of this on behalf of people with their tax money. So they are best placed as the authority to talk about this rather than leaving it to other people to explain it. That would be really, really welcome. And I think it'd be helpful. And, I think sometimes when people are unhappy with something, it's because their expectations haven't been managed appropriately. It's not necessarily that what they get isn't what they need, or that if their expectations are managed differently, they wouldn't be very happy with what they got. It's just that they've been told to expect something different. So I think, I mean, I would first rein in the way the government represents the NHS, because I think they perhaps build people's expectations too high, particularly around access to general practice as one particular thing, and then educate them about the reality. So I love it, and actually, my number 5 will complement this, Gandhi. You'll be very pleased to hear.
Oh, awesome! Well, let's crack on to your number 4 then. So let's switch that back over and see what Andy's number 4 was.
Looks like a reset. We'll have to suffer the animations of the first 3 again.
Make sure you don't overclick and go to number 5 by mistake.
Okay, so number 4. This one, so again, I'm introducing this to have the debate around it, because a lot of my patients would be unhappy to see me proposing this, I think. And I don't necessarily think this is the answer, but let's talk again about fees for GP appointments. Okay. Or appointments within the NHS. Prior to the pandemic, you'd go to meetings and people would talk seriously about this as a possibility. It's something that happens in other countries, that you pay what is sometimes not the full cost of the service, but a nominal fee for access to the service at that time. And this is an example of a passive system to manage demand. So we're not actively, so there's too much demand for the capacity. Okay. And there probably always will be. And some ways of managing demand involve active management that actually costs something for the organization. And there's an input of labor or effort, and people are making decisions based on information given to them about who gets access and when and where and so forth. And then there are other ways of accessing demand which are passive. So a simple example of this is actually you ask someone to pay £5 for something like a GP appointment, and actually one of the effects is that people who perhaps have had a cough for 2 days and they're not too worried, but because the service was free and perceived as low value, they'll ring up and want to talk about that, and often they'll get reassurance. But actually, if they actually need to pay something, then even if it's a small amount, then often that will moderate people's behaviors, such that those people who don't even believe they themselves really need it will back off and wait a little bit longer to make contact, freeing up resources for those people who really do need it. The flip side of this, of course, is that not everybody can pay. So this policy would come with many caveats, and there'd be groups of people for which it didn't apply, and there would be ways to claim it back afterwards for certain groups and so forth. So the devil would be in the detail, I think. But this is a principle. I think let's have that conversation, because more recently we've been having conversations about how you can send your GP a personal message, sat on the toilet at 2 a.m. on a Sunday morning, about something that's only just happened, and I think maybe we need to shift more away from access to actually the quality of those interactions. And this might be a way of passively managing the demand. I don't know. What do you think, Andy? You on board with this one?
So it's the plastic bag effect. We saw this also with plastic bags in shopping and stuff, that a simple introduction of a 5p charge reduced the usage of plastic bags by over 90%. So raises the question, would it have an impact? Absolutely, it would have an impact. I think, there are devils in the detail. There's the whole concept of who manages the bureaucracy of the charging, whose responsibility, whose is it if payment isn't made, is often the big question that many people make about these kind of discussions and stuff. And again, there's this whole concept of, well, if you charge people for an appointment, then that's going to further impact their quality of health because they won't seek healthcare. And I think that may be the case, but also what's the hidden burden of us having unrestricted demand, that therefore people can't access the healthcare system because we're so overloaded because of some elements of inappropriate demand. Not all. Important to remember that, whilst part of the reason we have overburdening demand right now is because we just don't have the workforce to cope with it. It's not because all of the demand is inappropriate. And often the challenge with that, you can only really determine inappropriate demand a while after the contact. It's not something you can measure at that point and stuff, which often a lot of media and other organizations and managers love to be able to do that, but the reality is you can't. I think you're right, though. We need to have the discussion. The current mode of failure is very much that we will never ever consider this, because we know that any government that does is probably writing themselves into the grave. Well, let's be honest, our current government have already done that. So this is probably the best and opportune time to have this discussion. Is this what the public want? And actually, a lot of the public forum kind of discussions do suggest that the mind shift is happening a little bit, that they may consider this if it meant more effective access as a result of it. So maybe.
Yeah, I get it. I was just gonna, so I'm being a little bit playful with this, but what I'm doing is, so there's this concept of Overton's window. Okay, so if you want to, there's a window of what it's acceptable to talk about, and that shifts over time. Okay, what they say, this is a tactic that you often see with politicians these days, is if you want an outcome that's maybe a little bit to the left or the right of where the main discussion is, what you do is you introduce an idea into the public dialogue that is way outside of Overton's window, so that people aren't talking about, but actually that widens what is discussed and what's acceptable, and then you can end up with an outcome that's kind of closer to where you want it to be, having deliberately shifted the discussion out in one direction. So maybe I'm trying to deploy that here. So, but Overton's window, just something to think about and look up. Right, I'm keen to know what your 5 is, the final.
All right, so my final one, it is, again, practical, doable. This is not a hard thing to make happen, but I think it would have a significant impact in the way that people approach their general practice and how they access care and that kind of stuff. And I think for GPs in particular, this would just be, game changing. Self-certification to 2 weeks.
I'm laughing because it's so simple. It's very simple compared to my number 5.
So for those that are watching this and think, what the flub is he talking about? Currently, you can self-certify off work for up to 7 calendar days for any illness that you currently have. You do not require a doctor's note for that period of time, irrespective of whether your HR department says they should do or don't. You can self-certify. But actually, I think changing this to 2 weeks is a moderate, measured, and appropriate approach that actually gives responsibility to the individual themselves in terms of looking after their healthcare, is realistic in terms of majority of health conditions, in terms of the timeframes that they would need to recover. So we are seeing, obviously, COVID was given 10 days because we knew that most people needed 10 days to recover from. Actually, the pressures of life and everything else currently, many people, rush themselves to get back into work and home life and all that kind of stuff. And actually, a lot of the times for viral infections, which is probably one of the key ones for a lot of this, is that you probably need over a week to recover from most kind of things effectively. Injuries, let's not push ourselves back to work quicker, but also it pushes that discussion back to employers to look at how they manage the workforce more effectively when there's health issues in that sense. And more importantly, it removes this rush to get documentation after just 7 calendar days. I know that some people are muted moving towards a month. I do think a month is too long, to be honest. 28 days, which is what temporarily did happen in January. So the government did actually, for about, I think it's about 8 weeks or so, change the legislation that self-certification notes went from 7 days to 28 days, whilst they asked general practice to up the vaccinations to prevent the third spike from crippling everybody and stuff, when that was, the third round of vaccinations and stuff that many people were being asked to have. So they've done it already before. It's just they went back to 7 days. And I think changing this to 2 weeks would have a significant impact both in GP workload, patient healthcare, employers' engagement in this kind of stuff, and change society's view on how we make healthcare work more effectively for you as an individual.
Yeah, I love it. I'm sold as well. I'm gonna push back there again. So, what somebody might say, oh, we'll get the calculators out and we'll work out the cost to the economy in terms of uh, people who inappropriately self-certify for 2 weeks is going to be billions of pounds to the economy. What say you to that?
So that's where it comes down to the employer's responsibility as well to manage and moderate the leave expectations and processes that occur in terms of health issues and stuff, because there then needs to be that aspect of supporting their employees as to what is the aspect of issues within work. You and I both know a lot of the reason people not self-certify but take absence from work is because of stress. Yeah. And they then come to us asking for time off to fix those stress poses. And the reality is 7 days is not often enough time to do that. Actually, having a slightly longer self-certification process may then encourage employers to look at the well-being of their staff more effectively and put in some of those processes in places in those organizations where unfortunately this is a driving factor, and an inward look in terms of fixing some of that, which then would have better well-being outcomes overall, so hopefully mean that more people can work for longer.
I'm sold on this, and I think in these shorter timescales, a lot of the judgment made by health professionals around whether it's appropriate to provide a certificate is based on what we hear from patients. Anyway, obviously they have to go through the hoop of contacting us after 1 week rather than 2 weeks, but actually the judgment we make is really based on their assessment of where they're at in terms of their health with that shorter self-limiting illness. So I don't think it would really, the outcome of whether they get 2 weeks or 1 week, I don't think that would be changed. I think that's often changed by a discussion with a GP. It might be different because they can't get access to the GP to have that discussion, but actually in terms of whether or not that certificate would be issued under the old or your new system, I don't think the outcome would change very much. So, but the level of workload in general practice in the NHS would change. So, we've got number 5.
Yeah.
So this one will be supportive of some of your measures, Gandhi. This is probably my most serious suggestion, I think, but it's still quite a big one. So, okay, so I'd like us to introduce something which I'm going to call the Office for NHS Responsibility. So this sounds very much like, say, the Office for Budget Responsibility, which we've talked about a lot recently in terms of Liz Truss, Kwasi Kwarteng, and what happened with the mini budget, the fiscal event, and that they didn't wait for their plans to be evaluated by the Office of Budget Responsibility. So what the Office of Budget Responsibility do is it's a government-funded organisation, but it sits separate outside of the government. It's independent, and it looks at the spending plans for the government, and it reaches conclusions about whether those are feasible, what effects those would have on the economy, and provides the sort of best expert assessment of that. And it's taken very seriously by the government and the general public, and it's got a good level of status. A problem with health policy that I see is that often politicians and the government will make statements about health or make government policy based on premises which I don't think necessarily add up. So, for example, claims about the GP workforce, for example, comes up a lot. Are we meeting the targets? Are we not meeting the targets? They say we are, but are we really? And it's very difficult to cut through that to the actual truth. And you need to get to the truth if you're going to make, policy that actually works, and make a difference. So if there was an Office for NHS Responsibility that actually looked at the statements made about health spending, about the health workforce, and actually provided an objective assessment of what the reality of the situation is or the effect of proposals, I think that would go a long way to improving the health policy that comes out of government. So that's what I would bring in. We didn't always have the Office of Budget Responsibility. I think George Osborne was the person that brought that in, but now it's very difficult to get rid of because everybody sees the benefit of it. So I would love for Rishi Sunak and Jeremy Hunt and Steve Barclay to bring in the Office of NHS Responsibility, and then evermore can we have more responsible health policy and not have ridiculous claims or knee-jerk policy reactions. That's what I'd like to see.
Here.
Yeah,
definitely behind that. I mean, you can see how some. So I mentioned earlier, some organisations do some aspects of this. In particular, I'm thinking the King's Fund tend to do a lot of work around this. NHS Confed, Health Foundation. That they challenge some of the rhetoric that comes out from this, but absolutely an official organisation whose responsibility is to fact check all those commentary and stuff that's made by organisations, just to say, actually, hold on, this is correct, this is not correct, this is an interpretation, and actually that you've taken the wrong end of the stick. I would love to see them have some stick to bash the media with on this aspect of things, that actually if you make a false claim in the media, then there is a consequence for it, because actually we know that some of the aspects of healthcare access, impact and stuff is very much driven by occasionally negative media perspectives that drive the problems. Morale in general practice is rock bottom, and a lot of that, the Daily Mail and Telegraph and all those organizations are absolutely responsible for some of that. So, an organization that turns around and says, actually, you did false commentary here, yes, with some teeth behind it to do so, I think would be absolutely, helpful for many people working across the NHS. And more importantly, give accurate information to our patients about the services that they're accessing, which is the key thing.
Absolutely. So very complementary to your previous NHS information point. So great. So I guess that's what we came up with in 15 minutes. It's really interesting to see how different the approach is that we took to those. I'm sure people out there will have their own ideas, and maybe as a little, it could make a good tweet thread, or certainly send comments in about the 5 novel ideas that people might have, or perhaps supporting other people's ideas for improving general practice. And maybe we can even submit that as response and comment to the Health Select Committee report and inform government policy.
Definitely. So as you can see, you've got Andy's General Practice Unleashed, Reborn as Family Medicine is 5 points there. So just to summarise that, so one-stop family medicine hubs in every community, and acute and chronic family medical care, prioritising continuity, also known as general practice. Activity-based contract for general practice partnerships. Funding follows demand, workforce follows. Other organisations will hold activity risk.
Not general practice.
Not general practice. Remove most strings attached to funding allocation. Practices make decisions about workforce in response to demand. Fee for GP appointments, passively managed demand. Many groups will be able to claim them back, but some will be exempt. An Office for NHS Responsibility, akin to the Budget Responsibility Organisation, checking politicians' maths and claims about NHS policy, staffing, funding announcements and plans. Switch over to mine. So I see mine sitting a little bit under yours, Andy. Your big headline kind of changes. Here's some more practical kind of stuff. So universal GP IT login, e-smart cards in terms of access. Twin that with a universal NHS jobs passport that would absolutely save a lot of bureaucracy across the NHS in terms of onboarding staff, managing staff elements and things. Change prescription exemptions, and I was going to chuck into their legislation around, prescription issues in terms of supply for pharmacies and things. An NHS public campaign on roles and services to basically help educate the population about how to use the NHS more effectively, both in terms of the clinical roles that now are available to see them and the services, more importantly on that part. And lastly, quick little fix, self-certification to 2 weeks would have so much impact and stuff, and I think would be amazing in terms of that. But that was our view, Andy. That's our quick fix to the NHS and general practice, trying to avoid all the stuff that's already been commented on. Obviously, there's, we could have talked about increasing funding to general practice. We could have talked about, various other legislation changes and stuff, but a lot of those have already been recommended by other people, and we wanted to be a little bit different, a little bit unique, and a little bit off the cuff as well. And hopefully people have found that useful for them.
That's good.
What do you?
And yeah, and really interested to know what 5 things other people would do to help general practice
It's
improve.
really interesting. Me and Andy, even though we do so much co-working together, we picked completely different things. I don't think there's any crossover really in any of those. Some symbiosis, but
Complementary,
yeah,
but not
complementary.
crossover.
But no, no real duplication or anything like that. So if in 15 minutes we can do that, we would love to see what you EGP learners get up to and do with that. So do let us know in the comments. Let us know what you think. Share this with other people. We really want to start this discussion. Actually, we'd love to see what people think. This came off the bat of our general practice, the future of general practice review from the Health Select Committee, which is somewhere here right now. You can have a look and watch out, and there we go. And as always, we're here to have tech enhance your primary care and learning. I'll catch you in the next episode.